Kyung Mo Kim from APPSGHAN Medical Center Children's Hospital, one of the big five in Korea. So Professor Kim will talk us through the ERCP in children, which is, as we know, this is very advanced procedure, and it's very difficult to meet such an expert like this. So please welcome Professor Kim.
Good afternoon, members of APPSGHAN. Thank you, Chairperson, for your kind introduction. It's a great honor for me to speak here at this prestigious APPSGHAN Endoscopy Masterclass. This is a picture of the APPSGHAN Medical Center located in east part of Seoul. World first ERCP was performed in adult in 1968. First pediatric ERCP was performed later in 1976. First Korean pediatric ERCP was performed on a 26-month-old girl with cholelococele in 1996, which was organized by me, a pediatrician, and the procedure was performed by an adult gastroenterologist. Number of pediatric ERCP is increasing due to increasing number of thoracic ERCP, even though a large number of diagnostic ERCP was replaced by MRCP. As you already know, ERCP is a combined endoscopic and radiologic procedure used for both diagnostic and therapeutic intervention within the pancreatic and biliary tree. The procedure utilized the simultaneous acquisition of endoscopic and fluoroscopic images and various therapeutic techniques. Side viewing endoscope passed via mouse down to the level of ampulla of vata and placement of a catheter into the bile or pancreatic duct so that contrast can be injected and the duct can be seen on the fluoroscopy. ERCP allows therapeutic intervention similar to percutaneous cholangiography, but does not require passage of needles into the liver, which includes stone interaction, stent placement, cytology and biopsy, and dilatation. Today I will overview the current status of pediatric ERCP. The specific contents consist of safety of ERCP in children, diagnostic and therapeutic ERCP in children. I will talk about safety of pediatric ERCP. This study is a meta-analysis of adverse events of over 3,000 pediatric ERCPs of over 2,000 children from 32 international centers. The overall adverse events was 6%. Post-ERCP pancreatitis was 3% and most common. The bleeding and perforation was less than 1%. The complication rate was similar to others reports. Post-ERCP pancreatitis in our center was 6.5%, which is a little bit higher than former meta-analysis. This might result from the higher proportion of therapeutic ERCP in our study. It showed tolerable safety of the pediatric ERCP. I will talk about endoscopic sphincterotomy briefly. Therapeutic ERCP usually needs a sphincterotomy before procedure. When performing a sphincterotomy, we have to consider safety issues. ESD can result in bleeding, perforation, pancreatitis during or after the procedure. In addition to it, ESD disrupts the sphincter, which has a barrier function, causing duodenal-biliary reflux, which can lead to gallstone formation, cholangitis, and malignancy in the long run. In other studies, ESD did not increase the risk of cholangitis, stone formation, and malignancy. The studies of short-term and long-term outcome of ESD in children is limited. We retrospectively studied the outcome of 271 ESD in 198 children. This showed a high success rate up to 97%. Acute procedure-related adverse events was tolerable. The post-ERCP pancreatitis was 5.5%, bleeding was 1.8%, and other major complication was less than 1%. We also retrospectively evaluated the long-term outcome of EST in children. This was the first study reported on the topic, as previously information was extrapolated from adult studies. The cholangitis stone formation was not increased, similar to the result from adult studies, and malignancy was not observed. Our study suggested that EST is a safe method for treating pancreaticobiliary disease even in the pediatric population. Even if you are not a pediatric doctor who perform ERCP directly, it is beneficial to accurately understand the indications of ERCP in children. Therefore, you can avoid unnecessary tests or surgical treatment by accurately understanding the disease that can be diagnosed and treated through ERCP. I just introduced the PEDI, Pediatric ERCP Database Initiative. PEDI is an international multi-center database comprised of 15 centers of patients less than 19 years old undergoing ERCP from May 2014 to May 2018. David Troender at UT Southwestern Medical Center is the PI of the project. I was fortunate to be involved in this project. From this database, many papers about pediatric ERCP can be published in the future. According to PEDI database this year, 72% of ERCP were caused by biliary tract disease, 22% by pancreatic disease, and 5% by pancreatic and biliary disease. Gallstone was the most common cause of biliary tract disease, and chronic pancreatitis was the most common cause of pancreatic disease. Most of the procedures, surprisingly 92%, were performed by a pediatrician working alone, which was higher than expected. About 7% were performed under the supervision of adult gastroenterologists. Only 1% of the cases were conducted alone by an adult gastroenterologist. Cannulation succeeded in 97% and showed results similar to those of adults. This slide is an analysis of the indication of a single center for childhood ERCP. While reports from West reported gallstone treatment as the main cause, reports from East in Korea, Japan, and India differed in that colorectal cyst was included as main cause. It shows that there was a regional difference in biliary tract disease. In pancreatic disease, chronic pancreatitis was a common indication in both East and West, showing the same indication. This is a table of typical indications of pediatric ERCP presented by APPSGHAN in its 2017 guidelines. I will briefly review the indication of pediatric ERCP according to this. I will talk about diagnostic ERCP first. I want to talk about ERCP in neonatal cholestasis. Studies suggested that ERCP is feasible with a pediatric side-view duodenoscopy without complications. They suggest that ERCP can be used as an additional diagnostic tool in the case of the failure of other investigation to confirm a diagnosis. For my personal experience, the technique of cannulation is very difficult, and there are uncertain risks of radiation exposure and general anesthesia for such a small baby. Therefore, we do not perform ERCP for the differential diagnosis of neonatal cholestasis in our center. This is a case of a 13-year-old male presented acute recurrent pancreatitis. ERCP showed anomalous union of pancreatico-biliary drainage. After endoscopic sphincterotomy, pancreatitis did not occur. APPSGHAN is known to be associated with colorectal cyst, GBM, bile duct carcinoma, and recurrent pancreatitis. Colorectal cyst has 5 types and various types of APPSGHAN. Only ERCP can precisely differentiate the types. This study from other colleagues at APPSGHAN Medical Center, who has helped us a lot in performing pediatric ERCP, this study showed that even though MRCP can replace diagnostic ERCP in various pancreatico-biliary disease, it has limited capacity to define ductal anomalies or small colorectal cyst. Exactly, ERCP can diagnose this precisely. This slide shows a case of PDUC anomaly correctly diagnosed with ERCP rather than MRCP. This is a case of a 12-year-old male presented with acute recurrent pancreatitis. Incomplete pancreas division was suspected in MRCP, but ERCP changed the diagnosis as completed pancreas division. Pancreatico-biliary malignancy is rare in children. This is a case of a 9-year-old female with inflammatory myofibroblastic tumor by exploratory laparotomy and biopsy, which showed ALK negative at the specimen. Repeated biopsy during ERCP for multiple stenting showed ALK positive. Therefore, alectinib, an off-label treatment, can be used to provide improvement. I will review the therapeutic ERCP briefly. One of the most common indications of therapeutic ERCP in children is to remove CVD stone. Recently, the incidence of gallstone in children is increasing, with increasing incidence of severe obesity. High prevalence of CVD stone is also noted in colorectal cyst in East region. EST or endoscopic papillary large balloon dilation is necessary prior to stone extraction. EPLBD is not indicated for children because it has a risk of pancreatitis and perforation. As for stone extraction, basket extraction, balloon extraction, and extraction after lithotripsy can be used. This is a case of 5-year-old girl presented with abdominal pain and jaundice. ERCP diagnosed colorectal cyst with a CVD stone. After EST, balloon stone removal was done. The remaining body stone was removed with basket extraction. The second common indication of therapeutic ERCP is the management of stricture. Malignant stricture was found to be rare in our previous study. Most of the biliary stricture was associated with colorectal cyst, liver transplantation, and primary sclerosing cholangitis. And most of the PDUC stricture was associated with pancreatitis. EST is always needed for prior to management. the dilatation with balloon or bougie dilator is necessary. Then stenting to the dilated stricture site was done. Single or multiple plastic stenting or metallic stenting can be applied according to patient status. There are lots of plastic stents. I prefer to use pigtail rather than straight to prevent stent migration. I will talk about metallic stent briefly. It has self-expandable capacity because of the steering force of this torque material. The metal was covered with silicone to prevent tissue embedding. It has a flaps, therefore migration occurs less frequently. It has longer patterns due to larger diameter. We use it for 6 months usually. In adult study, it shows more effectiveness than plastic stent. Our observational study was the first published on the use of fully covered self-expandable metallic stent in children. This initial experience showed that temporary placement of fully covered self-expandable metallic stent is feasible, safe, and effective for the management of refractory benign main pancreatic duct stricture in children. This is a case of a 10-year-old boy with bile duct anastomosis site stricture after liver transplantation. After sphincterotomy, bougie dilation was applied. Then plastic stent was applied. The plastic stent removed with improvement 3 months later. 10 years later, stricture recurred. We applied fully covered self-expandable stent this time. The metallic stent was removed with improvement 3 months later. I will talk about the hurdle in pediatric ERCP. Even though the incidence of gallstone in children is increasing, with the increasing incidence of severe obesity, the rate of incidence is relatively low compared to adults. In addition to it, pancreatobiliary malignancy is also very rare. Therefore, the volume of pediatric ERCP is very low. Due to small number of ERCPs, it is difficult to maintain a doctor dedicated to ERCP like for adults, and it is insufficient as a volume for education for trainee over a certain period of time. In my experience, even diagnosing ERCP is more difficult than colonoscopy. This is because ERCP requires technique of duodenal intubation of the endoscope and cannulation of major papilla. Therapeutic ERCP requires sphincterotomy as well as various techniques for performing the procedures. In our center, techniques requiring EUS, such as necrostectomy, are performed by the adult gastroenterologist alone. Optimal center-specific program needed to be created based on the level of pediatrician's technique, such as ability to operate alone, supervision by an adult gastroenterologist, and adult gastroenterologist operating alone, or a combination of these. In our center, we have been operating according to the level of case difficulty. I want to close my lecture with a summary. Pediatric ERCP is increasing. ERCP with endoscopic sphincterotomy is safe according to short-term and long-term reports, even though the number is limited. Center-specific pediatric ERCP program is necessary according to level of pediatrician's technique. The result of ongoing multi-center study from PEDI will be very helpful. Future procedure and training guideline is needed, although I did not mention here. This is a photo of our ERCP room. The team composed of one endoscopist fellow, one radiologist technician, 3 assisting nurses, and 1 anesthesiologist. Thank you for your attention.